So welcome to the COVID-19 and Emerging Infectious Diseases track. This session is Mashpee Wampanoag Service Unit, our COVID response story, and our presenters today are Rita Gonsalves, Leslie Mckeen, and Dr. Kelsey Simm. So I'm just going to go through the introductions for our presenters. So Rita was hired by the Nashville area office as CEO for the Mashpee Service Unit in 2010. She holds a master's degree in management and continues to guide the development of healthcare programs for the facility under the leadership of the Nashville area office. The successful establishment of Mashpee Service Unit was the first federal system of healthcare for Native Americans in the state of Massachusetts and the first federal service unit to have gone up in 30 years for the IHS. Rita is a registered nurse by trade, and her career began in 1992 at Brigham and Women's Hospital in Boston. And she also worked at UCLA Medical Center in Los Angeles. Both facilities set the pace and quality standards she brought to her position. She says her long-standing commitment to the tribal health and the Indian Health Service has been and continues to be a rewarding experience. Kelsey Simm is a family nurse practitioner who attended St. Anselm College for her undergraduate nursing degree. After that, she joined the Commissioned Corps as a senior co-step. Upon graduation, Kelsey began working at the Bureau of Prisons at FMC Devens, located in Western Massachusetts. A couple years after starting work, she chose to pursue her doctorate in nursing practice degree while continuing work full-time and graduated in 2014 from UMass Amherst. She began working after that as a nurse practitioner at the Mashpee Wampanoag Health Service Unit. She has 3 children, twins aged 3.5, and a younger son who is 1.5. Leslie Mckeen, our final presenter, is a dietitian diabetes coordinator. Leslie has an extensive multifaceted career in the field of nutrition and dietetics. She has worked as a dietitian at university, hospitals, and corporations, and in the qualitative food industry. Leslie developed the first diabetes program at the Mashpee Service Unit and is the coordinator for the Special Diabetes Program for Indians, or SDPI. When she is not working, she can be found at antique and open markets, displaying her vintage clothing collection or cuddling with her grandson, Cullen. So please join me in welcoming our presenters today, and I will get started with the presentation.
Good morning, everyone. My name is Rita Gonsalves, and I'm the CEO for the Mashpee Wampanoag Health Service Unit. What we're doing today is taking a look back and looking at our best practices in our response to COVID-19. We're going to tell our story. To begin, I'd like to take a look at the agenda and thank our leadership for their help and guidance during the pandemic. Dr. Beverly Cotton, Area Director, Mark Skinner, Executive Officer, Dr. Alex Thundercloud, Area Clinic Director, Dr. Wantina Johnson, Chief Medical Officer, and Dr. Vicki Claymore, Director of Field Operations. The presenters today are myself, Leslie Mckeen, dietitian, Lieutenant Commander Dr. Kelsey Simm, our family nurse practitioner. This will be a 60-minute presentation, and we'll have handouts at the end, our contact tracing policy, and directions to sign up for the TIMS. Before we begin the presentation, I'd like to do a brief introduction. This is the Mashpee Service Unit IHS. Our location is on the Mashpee Wampanoag Tribe's reservation. The service unit was established in 2010, and we have a dental clinic to the left. The administrative offices are in the center, and then to the right is the clinic building itself. We achieved our second accreditation in February of 2020. This picture represents the community that we serve, the Mashpee Wampanoag tribe. The Wampanoag Nation is located on Cape Cod in Massachusetts. The picture to the left is our tribal chief, Chief Silent Drum. The middle upper picture is our new chairman, Brian Whedon. Below that, our medicine man, Soaring Eagle, and to the right, Granny Squannet, one of our clan mothers. So traditional leaders are tribal chief, medicine man, and clan mothers of the Mashpee Wampanoag tribe. Elected leaders are chairman, vice chairman, treasurer, secretary, and 7-person tribal council. Before we begin this presentation, we'll overview both what participants will learn during the presentation and our best practices. Participants will learn our story as we look back from the service unit perspective to review our strategies and techniques that led to the successful response to a pandemic that this region had never encountered. Our review of best practices or lessons learned are as follows. 1. Communicate, prepare, and respond across all systems. Stay all on the same page. Number 2, slow the spread through contact tracing and case investigation. Number 3, cross-training. And number 4, vaccinate, vaccinate, vaccinate. These key strategies strengthened our capacity to serve the community and to uphold the mission of the Indian Health Service. When we review the slide, our first best practice, communicate, prepare, respond across all systems, stay all on the same page. As I look back at how Mashpee did it, we were in communication with the tribe, the Mashpee Wampanoag tribe, for a long time with emergency planning. Nashville area requested emergency operation plans, and so having all those plans in place and vetted was essential. And knowledge of how the plans work through a pandemic, that was new to me. Just reviewing authorities as they presented the opportunity to act in a pandemic. I can mention the Stafford Act. The Stafford Act authorizes the president to declare a major disaster or emergency in response to an incident or a threatened incident that overwhelms the response capabilities of a state or local government. That's what happened during the pandemic, COVID-19. There were several declarations I'll mention the one on March 13th when the president declared a nationwide emergency, and it was pursuant to the Stafford Disaster and Relief and Emergency Act. Later that month, on March 18th, our tribe, the Mashpee Wampanoag tribe, formally sent a declaration to FEMA. These declarations open up funding. So having knowledge of that and pre-planning and having strong emergency plans in place are very important on all levels. FEMA being the national level, and of course they have state levels also, tribal, municipalities, communities. They were all involved in the response plan, and all prior to the declaration. If there's a presidential declaration like the one that we had, a tribe may become a direct grantee or recipient of funding. In this case, the Mashpee tribe was a direct recipient. So having knowledge of that, plans changed with what they could contribute and what they had available for resources. So knowing all your resources is important. I knew that the tribe, well, I came to know, let me say that, during the declaration, that the tribe had a tribal approving official otherwise called a TAO. These agreements were in place. The tribe had a FEMA tribal agreement in place prior to the pandemic. So when this happened, really nothing needed to be done. The name of the emergency director was already in the system, and that allowed for ordering supplies for the tribe and knowledge of where to go for these resources, which was the national stockpile. So the national stockpile is very important during the pandemic, and who has access to it was important. During that declaration, as a direct recipient, we had access to CDC. There were deployments directly to the tribe. So working we really had access to a lot of levels being on the tribal reservation that we may not have had so quickly. And we also set up instant commands directly with Nashville, met daily with communicating on all levels how the tribe was doing, what distribution plans we had in place, how our emergency operations contingency plans were going to impact the service unit, pre-planning, communicating, and responding across all systems. It's very complex, but it can be done. Having resolutions in place, MOUs in place prior can be helpful. I was on the Tribal Emergency Response Task Force by resolution, so I already knew what the tribe expected our role to be if an emergency occurred. When that happened, we weren't expecting a pandemic, but we did have things in place, and I had been trained in ICS 100, 200, 300, and 700, so that's incident command systems. Huddle internally was really important for the staff to know where everybody was during the day. So these are best practices to know your resources and contacts. This slide and the two slides after this just show forms of communication for the system, both internal and external forms of communication. We'll start with the one on the right, which is our vulnerability assessment tool. So our team here, we call it SICQI, which is Safety, Infection Control, and Quality, reviewed our vulnerability to certain occurrences. This piece that I'm showing you now talks about naturally occurring events. And if you can see, epidemic, when we first did it, was only 22% or on the lower percentile of what we expected. But this is just showing you that planning ahead for different occurrences is vital. So this was on the table, we knew about it, and as soon as the epidemic started to spread or impact us, we met again, and of course these numbers changed. All of the numbers on the next couple of slides are not real numbers, it's just the tool that I'm showing. so that you could get an idea of what was used. An example is hurricane. It was high on our list, so for hurricane, we would have plans in place when a hurricane hit. So that's the purpose of this tool, is planning ahead and across all systems. The one to the left is the daily incident command tool that was reported back and forth through Nashville area. We let our leadership know on a daily basis how many people were positive, how many was being tracked, how many are vaccinated, so how much PPE we needed or if we did not need, and we were good with PPE. So showing tools and forms of communication for preparedness is important and a good strategy to have on hand. COVID-19 impacted our service unit. We had to quickly respond in a quality way to give the best care that we could to the community and our patients. The points of entry slide. So the points of entry for COVID-19 testing, when COVID hit and everybody needed testing, how could we do it safely? So the team collaborated. We vetted this through Nashville area. We spoke to the tribe about it, and we came up with the idea that we would have a couple of points of entry, because sometimes people were just walking in out of fear and just wanting to be tested. People were having symptoms and wanted to be tested. So how do you manage that? With this 2-point of entry system, we had one for patient calls in and you're given an appointment. And if we had a walk-in, we would be able to screen that person. We set up a mobile testing unit, a tent outside, that we would be able to screen and test that person outside. All the testing we decided to do outside through the mobile testing unit, and that was a decision that came about quickly in order to keep the non-COVID patients safer. We were still able to see our primary care patients internally, and we ended up setting up a mobile testing unit exterior to the service unit in the parking lot. Let's see, we had all patients and visitors that walked in had to be screened. So knowing that ahead of time, it was difficult, but we had temperatures at the front, and we had a sign asking if you had any of these symptoms at the front door. So all patients and visitors, either walk in or by appointment, were screened for entry into the service unit. A very important part of our response to COVID-19 was our tribal collaborations. That's why we're here, to look out and have the best interest of the tribe at hand. I had mentioned the TERFT, or the Tribal Emergency Response Task Force. We met daily to review the needs of the community. Early on, we noticed a need in the homeless population. Okay, so I myself wrote a policy and got it approved through Nashville to house any homeless COVID positive patients, because not having anywhere to quarantine or isolate would spread amongst the community. So I was able to get that approved. In addition, the tribe themselves created a homeless accommodations policy where even for a quarantine, they could go in, even if a person did not have COVID but needed to be quarantined or come out of the home because the person that was positive was inside the home, and it could have been an elder or someone that needed to stay in the home. So we had a setup where the tribe could house a person that was quarantined and not just isolated due to COVID. We gave testing support amongst the tribe and all of our staff through surveillance. We were doing a lot of surveillance, weekly surveillance of workers in the community. I really wanted to highlight the best practice of being able to help with home accommodations and food. The tribal housing department also, they had in place 3 motels where homeless could be housed to get off the street during COVID. So having all those resources, our homeless policy where we could actually house a COVID positive patient, the tribe's resource where if a tribal member wanted to quarantine out of their home or needed food, we would have that set up. Many evenings I would ride out with the emergency manager and drop off food and supplies to the hotels as we were fighting this illness. And the picture, this is what we do it all for our families, for our tribal families. It was very difficult to be separated from children and your family when you're sick. But at this point, that was the only treatment that was given for the COVID, was to quarantine or isolate. So, and not having the accommodation to do so was a barrier. So we're very happy with our ability to be able to overcome that barrier of housing and food accommodation through tribal collaboration and of course Nashville area. Because if you're isolated, you cannot come out and get food. How can the person go to the store if we say stay isolated for 14 days? And so we took that into consideration, and we were able to bring food to that family or to that person.
Hi, my name is Leslie Mckeen, and I'm going to talk about the second best practice, which is slowing the spread through contact tracing and case investigation. By now, many of people have heard of contact tracing and case investigation. Previously, these were 2 descriptors that I knew little, if anything, about prior to March of 2020. Yet it's a practice that's been in existence for many decades. It's used in breaking the transmission of infectious disease, and has commonly been used in battling diseases like tuberculosis and Ebola. Shortly into the pandemic, around May or April of 2020, probably around the same time that we began testing for COVID, we were fortunate enough to receive some training and education about the principles and process of contact tracing. This education provided us with the framework of knowledge of which we built upon. We understood that interrupting the spread of COVID was one of the single most important things at that time that needed to be accomplished if we were to keep our community as safe as possible. With this in mind, and under the direction of our area authorities in Nashville, we began to develop our own contact tracing program within our small tribal community. Establishing a supportive and comprehensive program was essential in controlling the transmission of COVID and all its implications. Our partnership with Emergency Management Division of the tribe was pivotal, really, in creating a broad program that would foster many facets of care and assistance. The majority of contact tracing and case investigation training was completed through the CDC as well as through Johns Hopkins. This remains ongoing as guidelines change and more information becomes available. We initially started with 2 primary contact tracers and a third as a backup. At the present time, there's 1 tracer and 1 backup. Initially, our program was set up to just follow 5 basic fundamental steps. The first was to identify cases. The second was to interview cases and develop a contact list. Third was to notify close contacts of exposure. Fourth was to provide instruction on isolation and quarantine, share information about COVID, and offer testing. And lastly, we monitored cases and potential cases throughout their quarantine and isolation period. We typically followed up once after the initial connection and found that this could be more or less depending on the situation. If a person was medically compromised, for example, we may have followed up more often. Within this basic framework, we discovered and aimed for a number of other targets. The timeliness of case identification and tracing measures were really critical in interrupting the disease transmission. Reducing the spread meant that we needed to notify those affected and initiate contact tracing measures swiftly upon receiving test results. In most cases, we were able to commence the measures within 24 hours, thereby preventing further spread. Initially, when we did first start testing, we didn't have a laboratory nearby, so the tests were being sent out from Massachusetts to California, and it often took 2 weeks to get results back, which really negated any contact tracing efforts whatsoever. So we knew that quick turnaround times for laboratory test results had a great impact on how quickly we were able to respond. If results were delayed, then so was our response. The average time has been about 2 days for the PCR test results to come back, but last winter results were taken up to 7 days, which really impacted our efforts. We have since purchased a rapid testing device as well as home test kits. So monitoring cases throughout the isolation and quarantine period was often challenging just due to the number of contact traces we had and the number of cases. So we developed, or implemented, I should say, the digital monitoring system that's used by the CDC. It's also called TIMS, which is the acronym for Text Illness Messaging System. It's primarily used as a way of monitoring symptoms in individuals with exposure to an infectious disease. It's also been used for a long time. It allows for a two-way message to be delivered back and forth from an individual to an organization regarding developing or worsening symptoms from an exposure, which in our case is COVID. It's a simple one-tier text message which allows us to manage and respond to rising cases or worsening conditions quickly. The message can be personalized, which is really what we did. We changed the message to include information about what to do after business hours with providing a number, and also what to do in an emergency situation. We did learn that this provided some degree of comfort to people who were worried, and the comfort was really in knowing that a person would be calling to check in on their well-being. One of the downsides of this system that we also discovered is that it's of limited value to the elderly due to the nature of its platform. In these cases, we actually just used the phone for follow-up, which tended to work better. The TIM system was also used as part of community surveillance. In fact, that's what we started with, was just monitoring the community at large. Enrollment was really up to the individual, but again, they would receive the message every day asking if they had any symptoms. We use it for contact tracing, and then later we also adapted the system to be used for any adverse symptoms related to vaccine administration. So it's pretty simple. We just provided the instructions at the time of vaccination. We also offered the TIM system, which is a voluntary system, of course, to people as we were notifying them of the need to isolate or quarantine. We have done a lot of data collection since initiating testing here at the service unit. And this is a slide just depicting some of the data that we analyze. this data is related to symptoms related to positive COVID test. We also look at things like the number of individuals exposed to each positive case. We look at degree of illness, and recently we just added another data field to monitor vaccination status on all new cases of COVID and the number of to measure the number of breakthrough cases. There were several potential super spreader events in which our alliance with the contact tracing Cape Cod Collaborative, that's a mouthful, was of inordinate value. The Community Tracing Collaborative, what they'll do is they'll investigate transmissional events further, and they conduct more retrospective tracing. So that liaison has been also very important to us in monitoring cases where there are potential super spreaders, and it just kind of goes beyond our capacity here. One of the other things that was done was there was a supplemental script that was added in the testing that was done outside of our facility. So anybody who had a test done outside of our facility that came back positive, the VNA is using a supplemental script that was implemented to identify any enrolled tribal members that needed contact tracing, and also just for our data collection. The last area I'm going to talk about with our program is, and it's probably one of the most important, is the significance of the quality of isolation and quarantine. The benefits of contact tracing really depend on one's ability to comply with quarantine and isolation guidelines. Compliance with self-isolation and quarantine is often dependent upon what supportive services are available to make that happen. Determinants of quality are really reflective in the additional care and assistance provided while folks are in isolation or quarantine. For many people, we found that providing these wraparound services such as food, prescription refills, over-the-counter medications, and alternate housing were necessary in order to achieve this quality and compliance. Partnership with Emergency Management Division again was essential in making this aspect of the program possible. The food bank director also at the tribe was essential again in providing food for people at home and those in alternate housing sites. She was remarkable in just going out and getting special items that people needed and making sure that they got to them. Sanitation supplies, thermometers, pulse ox machines, even air purifiers and dehumidifiers were routinely offered and provided. So in our experience, we found that these measures allowed individuals to carry out the period of isolation with greater compliance. And this slide just kind of shows us following up to see how well people did actually comply. One of the barriers, of course, that we heard over and over again, we heard it all too often, was that the financial deprivation or loss of wage made this often difficult to comply with this long period of isolation, especially when the guidelines were 14 days. We found that when the CDC reduced the quarantine guidelines, it really helped alleviate some of this hardship. As we move into fall with school openings and in-person learning, along with an uptick of cases in Massachusetts, especially the Barnstable County, which is where we're located, we're updating our contact information within the school system. We're reviewing our strategies and reporting systems, renewing our contacts, and just making sure that we're ready for when the schools open within the next few weeks. So I think that's all I have to say on the second best practice. Thank you for listening.
Hello, this is Rita Gonsalves again reporting on our third pandemic best practice, cross-training, where we utilize staff in other roles as needed to prepare for impacts to the service unit for potential absences due to COVID-19. The COVID-19 pandemic thrust our service unit into a rapid response. We needed a way to meet the staffing demands and the needs of our patients. We wanted the best outcomes for both patients and staff. Cross-training measures help to improve safety for our frontline staff by allowing alternate staff to share the common workload. It also helped to keep us motivated by allowing more flexibility with day-to-day operations. The service unit response plan included cross-training and alternate work schedules. This allowed our workforce to have the increased flexibility and sustainability necessary to perform their duties. Not knowing what percent of the workforce may be affected by COVID-19 at any time, we went with a team-based approach, alternating the frontline team on-site with a frontline team off-site doing telework. This way, we had backup staff and the ability to improve our response to COVID-19. The next slide is a picture of our drive-through COVID-19 testing tent located outside the service unit. In looking back at lessons learned, we can show you where our cross-training was most utilized. This may offer an option in addressing staffing shortages. The drive-through COVID-19 testing site is a complete self-contained mobile medical shelter, easily stored and towed with the ability to remain on-site and rapidly deploy when necessary. With the expansion of services, the community was able to come in safely for testing with a shelter designed for medical use. This, along with the rotating staff pattern and staff cross-training, was vital and supported our service unit capacity to implement the drive-through testing program at Mashpee. The CDC provides guidance on mitigating staff shortages. Their resource is Strategies to Mitigate Healthcare Personnel Staffing Shortages, located on their website. The slide shows the Binex and the PCR testing. That's what we were doing at mostly in this tent. The Binex is the 15-minute turnaround test with lab results, and the PCR was the send-out lab. We did have a contract with a lab for send-outs. We only offer a CLIA waived lab on site, and PCR was not CLIA waived. Early on in the testing, labs were coming back quickly, 1 to 2 day turnaround. But as we all felt the impact of the COVID and the testings increased, the capacity of the lab we had a contract with couldn't handle it. So early on, well, I shouldn't say early on, but midway when the testing was getting more difficult, our turnaround times were going out 7 to 10 days. So with that happening, we put things in place that needed a quicker turnaround. We had a plan for healthcare professionals and tribal officials. We used color-coded slips if we needed a quicker turnaround. And then also during that time, the lab created another site to help improve their capacity to handle and manage all of the labs that were coming forward. So it was on both ends, but we did have a plan in place to help improve turnaround time. This slide is an important slide. Not only does it show our fourth and final best practice as we look back at lessons learned, which is vaccinate, 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 but it's a picture of our frontline staff. Well, most of them. There are some that's not in the picture. But these are the people, our boots on the ground, that were there to serve the overall mission of the Indian Health Service, which is to raise the physical, mental, social, and spiritual health of American Indians and Alaska Natives to the highest level. This picture was taken on March 19th, 2021 in 31-degree weather with wind gusts up to 50 miles per hour. This is when the Mashpee Service Unit, IHS, implemented our first drive-through vaccine clinic. We administered over 100 vaccines that day to local community members. We collaborated with municipalities and systems in the area to do this. This was phase 4 of our vaccine distribution when we went outside of our primary deliverables, which were Native Americans. So we went outside within the community and did a drive-through, which was very successful. I want to thank all of the Mashpee Service Unit and the staff there that made this possible. Like I said, those that weren't in this picture, we have a tremendous staff. And this is one day, was one of many days that the staff came forth for the mission and for the Wampanoag community and the community beyond to help mitigate COVID-19. So vaccinate, 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 and the vaccines will be an important tool to help stop this pandemic.
Hello everybody, I'm Kelsey Simm. I'm the nurse practitioner at the Mashpee Wampanoag Health Service Unit, and I'm going to be talking about the phase of delivery for our vaccination rollout. As we've talked about before in this presentation, part of what made this so successful for us was our pre-planning before initiating the rollout, which was done in collaboration with the tribe. As you can see from this slide, the left shows the service unit's vaccination timeline, and the right is demonstrating the state's vaccination timeline. And this is one of the areas where we felt that the size of our population was very beneficial to the rollout of the vaccine, because we were able to disseminate information quickly and also make contact with our patients quickly, which for a larger population really would not have been possible. The importance of cross-training and teamwork really cannot be overemphasized when we're talking about the vaccine rollout and the vaccine phases. And for us, what that looked like was a team approach to reaching out to all individuals within a single phase of our plan. And then once we had ensured that we had either vaccinated or received a refusal for the vaccine from all patients within a phase, we're able to rapidly progress to the next phase. And as you can see, we're able to reach older adults, the 65 plus population, at a much faster rate than the state, largely in part because we were proactive in our approach and we were actively looking to progress to the next phase instead of waiting until a pre-established date. And one of the results of this is that we're able to vaccinate the teachers of the Mashpee school system prior to widespread availability of the vaccine to educators. And if you look at the final phases where the vaccine becomes widely available, you can see we were able to get to this point by March, whereas the state wasn't able to do this until May. And again, that has a lot to do with our population size, but we are immensely proud of this and immensely proud of the team effort that went into it to make this happen.
Okay, now this takes us to our final slide. Where are we now? I'm sitting here with my team and we're discussing where are we now, and we're looking back at our best practices and figuring out if we are heading in the right direction dealing with the Delta variant. Taking a look at the slide, we're standing up our incident command team. We've taken on board a new supervisor, a wonderful physician, Dr. Neil Borgia. He has to look at our processes, what we've done in the past, and how we're going to move forward. We're monitoring our breakthrough cases. We're continuing the mask mandate and preparing for school openings. And how is the Delta variant and the increase in positivity going to impact the school system and our service unit? We're revising the organizational landscape for public health concentration with process improvements, looking at the impacts of COVID-19 on the service unit. It had an impact on our direct services, and we are looking at establishing a public health division in concentration, so to be able to specialize in that area if needed. The special general memorandum is come to us, and so we're reviewing that and seeing how that's going to impact our staff. Dr. Borgia, where are we now? How do you see it? How do you see the service unit moving forward?
Thank you, Rita, and hello everybody. This is Dr. Borgia. So it has been one of the privileges I've had with joining the MASHP team is the fact that they have really taken this pandemic seriously and have established procedures in place and really a team approach to the pandemic with the previous variants. Now with the Delta variant, unfortunately we are faced with a new strain that we all know now is much more contagious. And as some of the recent data is showing, there is an increase in breakthrough infections as well as possibilities of even vaccinated patients experiencing more likelihood of hospitalization and even potentially more death. So it is essential to really continue to maximize the procedures that are currently in place, including masking. We want to make sure that we continue and really stress the mask mandate. It is easy to, as many of us have experienced, it's really easy to just take for granted stopping the use of masking, because all of us want to stop masks. All of us are kind of tired of using masks, but it is even more important now to really continue to emphasize this with our patients, with our staff, that the service units do have mandatory masking. This also includes screening. We have a robust screening policy in place for all staff and employees, where we're doing COVID screening every 2 weeks. We also recognize that vaccines are the best tool for helping to prevent the spread of COVID, including the Delta variant and hopefully any other future variants. And so we are wanting to really address and aim at the school-age population. As schools start up and colleges start up, we want to make sure that all of our school-aged members and patients are getting the appropriate COVID vaccines before they're heading back to schools and universities this fall. And then last, with this special general memorandum, we want to make sure that any of our unvaccinated employees do comply with the requirements of vaccinations by the October date. All of these components are really put in place to continue to prevent COVID and to protect our patients as well as our staff members from the Delta variant and any future variants which we may have to face in the near future.
Thank you, Dr. Borgia. I think we're really lucky that we have a framework to look at. We know that our best practices were to communicate across the systems, to slow the spread, to cross-train, and to vaccinate. Where are we now, Leslie, in our framework? What's going on with our service unit?
We have a meeting. We actually have a meeting this week with our community and county liaisons with the Community Collaborative Contact Tracing Division as well as with emergency management, with the school system liaisons, and we'll be discussing our approach to school reopenings and kind of reevaluating our strategies and making sure that our contact information is up to date, so that in the event of positive cases coming through, our response is going to be quick. And yeah, I think that we're doing everything in our power that we can do. And kind of looking back on this past year and a half, it's pretty amazing, the collective and unified approach that we've taken in working with our community and working with the tribe in preventing the spread of this disease. We really are, as they say, Mashpee strong. So, thank you.
Rita, if you don't mind, I wanted to add one other thing. The other thing that COVID is forcing us to all be is rather fluid with the changes, with the new variants and new data that comes out, including, for example, the possibility of boosters in the future. So I think that we as a group here at Mashpee have really been able to come together and work to be flexible when necessary and address the changes as they come along, address any new issues as they come along.
Thank you. So we still have a lot of work to do and monitoring for our community. But I think that will end our presentation for today. And
Thank you for listening.
yeah, thank you all.
Thank you.
So I hope you can join me in thanking Rita Gonsalves, Kelsey, Simm, and Leslie Mckeen, as well as Dr. Borsha.